Okay. So we have been actually examining the meaning of the letters NCCIH. And I'm going to be taking you this little exercise, starting with the middle C letter, complementary. So what does complementary mean exactly? And in the past, the way we've sort of defined complementary is sort of, these are practices and treatments that are considered to be sort of outside of conventional medicine. But what is really considered mainstream versus non-mainstream is starting to become a little bit more blurred. For example, we've mapped out some of the types of complementary and integrative practices here on this sort of diagram and organized them in different domains. So for example, dietary, psychological, physical interventions, but also more other types of more conventional domains like drugs and devices and even surgery. And as you can see, there's some overlap here. And even within some of the modalities that we consider to be more conventional, like for example, cognitive behavior therapy, which is generally considered part of sort of conventional psychotherapy, more and more sort of CBT techniques are incorporating elements of, for example, meditation, mindfulness, relaxation techniques. Also, same thing in the physical domain. For example, a lot of physical therapy practices are incorporating manual therapy techniques that are derived from, you know, massage or spinal manipulation. So it's becoming sort of more blurred as to what's less conventional versus more conventional or more complementary. There's also interesting overlap between the different domains of dietary, psychological, and physical. For example, here we have sort of mapped things according to what we call the predominant or dominant sort of therapeutic input. For example, here, dietary, clearly things that you ingest. But between psychological and physical, sometimes you can see that it's not quite clear where things belong. Some practices such as medication, for example, the predominant, I would say, psychological input is mostly mental, although there is a physical component. Of course, breathing, for example, is part of a lot of meditative practices. Other types of, say, physical interventions are predominantly physical, like manual therapies. The predominant input is via, you know, touching and sort of manual contact with the patient. But there's certainly also a psychological component to this as well. But there are other practices, like for example, yoga and Tai Chi, that clearly are very much both psychological and physical, and really sit more in between. So there's an interesting sort of way to look at this. Also very interesting if you look at something like acupuncture, sits in an interesting place here. And there's clearly a psychological component to acupuncture and a physical component. It's a physical type, you know, using needles, but also needles are a device, a form of device. So it's interesting to think about where these different types of therapies map out. Now, it's also interesting to see where these types of categories map in relationship to other ways of classifying. For example, at NCCIH, our previous way to think about the types of you know, research that NCCIH funded, we were characterizing it in terms of either mind and body practices versus natural products. And you know, these were the two large categories of types of research that NCCIH was funding before. And as you can see, there's an overlap. It's not exactly mapped out onto these categories of dietary, psychological, and physical, but pretty close. But we think that this sort of other way of looking at all these different domains is a little bit more inclusive. And so, this is not meant to be a definition by any manner of means, but more of a description of the type of research that NCCIH might fund, which would include complementary therapies and practices that use dietary, physical, and/or psychological approaches, and may have originated outside of conventional medicine, but may have not. Now, now let's look at the letter. I, the next letter, integrative. Now, when we think about integrative health or integrative medicine, we usually think about integrating complementary and conventional types of therapies, and that's true. But we've also been at NCCIH thinking a lot about other components of integration. What else could integrative health be integrating? So if we think about this in a very general sense, if you think about, whether you're looking at biology or even mathematics or any types of science or even philosophy, there are different sort of countercurrents we could call of analysis and synthesis, right? Analysis is when you break things down into different, components to try to sort of get at the details. And then synthesis is when you kind of put it back together and arrive at a bigger picture. And so these are very, these happen all the time. There's always, in all of the research, you have analytic components and synthetic components. But in medicine, really, I think it's fair to say that we are very much driven towards analysis. There's a strong tendency to break things down into components to try to really arrive at specific mechanisms. For example, we look at, so within different organ systems, and within different organ systems, we look at different cells, and then within a cell, we look at different pathways and molecules. And, pretty much there's a strong tendency to really want to look at the molecular level. And, this predominantly sort of analytic approach has really led to one of the sort of dominant sort of forms of treatment in medicine, which is pharmacology, which is really sort of trying to arrive at treating a disease, for example, at a very basic, specific molecular level. For example, interacting with a specific receptor on a cell to really target specifically what the underlying abnormality might be. But if you think about the countercurrent that goes towards synthesis, there's still a lot of that going on. In fact, more and more, there's a knowledge or an understanding of looking at the biopsychosocial aspects of a patient or an illness. And for example, internal medicine, family medicine, there's a lot of geriatrics. I mean, there's a lot of different medical specialties that really are emphasizing this kind of whole person approach to health. So there are both going on, and I have to say, even in basic science, there's been more and more of a realization that synthesis is important, and we've been missing some of it. In fact, systems biology now is an important new development, right? A relatively new development in physiology, which is really trying to understand how the various systems of the body interact. And for example, also genome, right? Genome-wide association studies are moving away from the idea that it's really just one gene and or one disease. That there's many times there's these networks of genes that kind of contribute to a given phenotype. Nevertheless, I think it's fair to say that a lot of medicine is still organized very much in a systems by system manner, because that's how medicine is organized. All the medical specialties, the medical school departments, and that's how a lot of even NIH is organized, right? It's by organ system for the large part. And this is really dominating a lot of our thinking, and to the point where we know generally a lot more of what happens within a system as opposed to between systems. Now, there are efforts that, and at NCCIH, we're very interested in this, in how the various organ systems might interact. An example of this is the field of interoception. This is how the nervous system, the brain, and kind of interacts with the different organ systems, and how the body interprets the various signals that are generated among all the various organs of the bodies and systems, and then kind of interprets these signals and then processes them and integrates them. So, this field is a relatively young field. A lot of it involves, the autonomic nervous system, which we have, of course, known for a long time. But it's also interesting, too, I think, to think about other ways that the body might be organized in terms of its connections. And so here was sort of illustrated, just for fun, 3 different ways that you could think about it. So we have the brain-centric view of things, right, and in the middle, and then on the left, you have the gut-centric view of things, which is really, in a way now, becoming more and more of a fascination with our understanding of the microbiome and how so much of what goes on in our digestive system influences what goes on in a lot of other parts of the body, including the brain. Now, on the right, I've illustrated another interesting way, which is the musculoskeletal centric, which is maybe not quite so obvious, but if you talk to people who do, for example, osteopathy, they will tell you that, well, you know, you can really view the body very much from the point of view of the musculoskeletal system as a point of entry, and that manipulation of the musculoskeletal system can have effects on other organ systems. And the more we start to understand this in terms of somatovisceral connections, the more this really starts to make sense. And so it's really kind of fun, I think, also to map out these 3 different, various different ways of thinking about these connections and map them out onto our dietary, psychological, and physical connections. And therapies. And I think another fun fact to think about is that these 3 different types of kind of ways of viewing the body also map out to some of the basic, right, embryological layers, you know, endoderm, mesoderm, and ectoderm, where you think about endoderm is what's going on in the inside, right, the gut, and then the ectoderm is what's going on in the nervous system and the skin on the outside, and then you have that middle mesoderm level layer that involves the not only the musculoskeletal system, but also, well, mesenchyme and mesenchymal derived tissues, including blood, immune system, etc. I think it's kind of interesting. So going back to that letter I hope that this is kind of conveys to you how we think about integration more than just integrating complementary and conventional care. There's a lot of room for better understanding how the whole body is integrated. And I think that complementary and integrative health can be instrumental in illustrating some of that and better understanding it. Let's move on to H, health. So health, I mean, clearly, you know, in medicine is very disease focused, right? We think a lot about disease. And health is, we think of health more in terms of prevention, right? Preventive medicine, promoting health. And even preventing medicine, however, is very much focused on preventing disease. Now, I think that following the previous discussion about whole body versus different organs, you know, when we think about disease, we really tend to be organ focused. When we think about health, it's more of a holistic concept. We talk about heart health and brain health, but really, you know, when you're healthy, it's more of a whole person kind of, although it's hard to define sometimes, but it just then generally tends to be more of a holistic kind of whole person concept. Now, the important thing also is that health and disease are not separate states. There are stages in between. And so if we start from a healthy state and go towards a disease state, very often, especially in a lot of the chronic diseases that are extremely common, you go through this kind of middle stage where you start perhaps with a behavioral issue, like, for example, poor diet, but then would lead to some sort of gradual developing biochemical abnormalities, such, for example, elevation of the blood sugar, the hemoglobin A1C, where you haven't quite reached the disease state, but then there's starting to be some measurable phenomena that are happening that are showing that there's some disturbance, right, in the metabolism. And now where this sort of dotted line here lies, where is the demarcation between pre-disease and disease, usually is kind of where people decide, you know, well, okay, now it's time for treating with drugs, right? That's usually the kind of the threshold. And there's a general sense that as long as one hasn't reached that stage, that there's a potential for reversibility. Once you've sort of crossed over a disease, reversibility of the biochemical or physiological abnormalities are more difficult, not impossible, but maybe more difficult, right, to get back towards health. But how do you move those green arrows back towards health? How do you restore health? This is an aspect of preventive medicine that is part of secondary prevention, but is not studied quite as much as preventing, right, disease, preventing those red arrows to go towards disease. Now, the other thing that we understand is that sort of disease, these sort of issues with diet, for example, not only lead to diabetes, but also hyperlipidemia, weight gain that can then develop into diseases of different organs, including cardiovascular disease. And that very often, the same people who have issues with, poor diet also can have a sedentary lifestyle that can lead them to other problems. For example, weight gain. A lot of people will then develop problems with with musculoskeletal pain, back pain, joint pain, and then eventually degenerative joint diseases that go hand in hand with an unhealthy lifestyle. In addition, very many of the same people will also have some psychological stress and poor sleep that gets exacerbated by not getting enough exercise, and perhaps having some chronic pain, difficulty sleeping. And so you can see that a lot of these conditions that when you are at the disease state are considered comorbid, right, are in fact maybe derived from some sort of common ancestors, essentially, which are the behavioral problems, right? And sadly, these are very much some of the same people who are unfortunately disproportionately affected by the coronavirus right now. So, these are obviously these sort of chronic, what we call the non-communicable diseases that are sources of extremely common suffering and a lot of disability and poor function. So, whoops. Whoops. I'm sorry. Move my thing. What we're starting to realize, however, is a lot of these conditions have some pathophysiological elements in common. And one of the important elements of this is inflammation. We know that, for example, even chronic psychological stress can lead to a chronic inflammatory state. Certainly obesity can, certainly chronic degenerative joint disease. And we now understand that inflammation is not something that really sort of stops at one organ system. There's definitely a crossover in pathophysiology. And also, if we kind of go back and rewind the clock, you can see that the same elements, behavioral elements, psychological stress, poor diet, sedentary lifestyle, really kind of have an influence on many of these chronic diseases. The important thing that we can consider here from the point of view of complementary and integrative health is how do we understand better how combining dietary, psychological, and physical interventions, both from the point of view of self-care and interventions, can help to restore health, to bring back a state of improved health and well-being. So how we have sort of, this is represented here, is this slide kind of illustrates how looking at the health disease spectrum in a bidirectional way shows that it can include both a return to improved health in addition to preventive disease. And in addition, taking a whole person approach, including the connections across physiological systems, can help us better understand how behavior can influence this health disease continuum. Now, of course, a very important question here is, well, how do you measure this, right? How would you be able to measure somebody who returns to a better state of health? Well, we're starting to work on this and understand better some of the positive outcomes that may be associated with what we call health restoration. We know a lot, of course, about negative outcomes of, for example, emotional stress, pain, fatigue, etc. But what about positive outcomes like physical and emotional well-being, resistance, stamina? These are important measurements that we need to understand better how to make. And this is an area where there's a lot of interest throughout all of NIH, is to better understand how to measure these. Now, what about mechanisms? Well, we understand that, of course, we know a lot about sort of mechanisms of disease like inflammation, dysregulation, fibrosis, thrombosis, etc. But what about positive mechanisms? Mechanisms that mediate a return back to health. We don't know so much about this, but there's starting to be some very, very interesting research in the domains of repair, resolution, recovery, regeneration, all these wonderful words that starts with R. And these are all kind of indications that the body is returning to a better state of health. And yes, the other thing that's very important to understand is how these mechanisms of repair and regeneration and resolution would also go hand in hand with an improved resilience at a psychological or mental and emotional level. So going back to then our definition or description of what the health means, we are now incorporating, right, health promotion and restoration, disease prevention and symptom management into one continuum. Symptom management is clearly very important, but it's not, we want to really kind of consider it together with the whole sort of health disease spectrum. So now putting everything back together, I'm showing you this now, not to say that this is something, these languages are set in stone, but these is basically our thinking at the moment as to how to sort of start structuring how we are thinking about complementary and integrative health at NCCIH. So I've talked now about whole person health and in various different kind of illustrations. Whole person being sort of an integrative approach to both physiology, pathophysiology, and treatment, and health meaning the sort of bidirectional health disease spectrum. But there's something else that we want to talk about here is the concept of both complementary therapies in what we call whole health systems. Now, whole health systems is something that used to be part of the sort of strategic plan at NCCIH in some of the earlier plans, but has not quite been so in recent ones. And I think the reason for that is that there was, it's a complicated issue, and developing methods to study whole health systems is quite tricky and complicated. And as I will talk about a little bit later, we think that now we have arrived at a stage where we feel confident that, we can actually address some of the whole health systems that perhaps 10 years ago, we really didn't know, how to address them in a way that could bear fruit. So let's think about what whole systems mean. Well, I think there's a nice parallel between complementary therapies and whole health systems, where if you think that with the complementary therapies, we have dietary, physical, and or psychological approaches. In whole health systems, we think about them as approaches that are combined, right, in a multimodal way that address multiple aspects of a person. And then if we say similarly, if complementary therapies may have originated outside of conventional medicine, whole health systems have an added dimension, which is that they may use diagnostic and or therapeutic frameworks that are different from those of conventional medicine. That makes them more complex and also more tricky and difficult to study in a research way, but we think not obviously impossible. Let's look at some examples of this. If we go back to our dietary, psychological, and physical domains, if we think about types of whole health systems that might be very sort of conventional, for example, an integrative approach to cardiac rehabilitation might include a dietary intervention, some mindfulness techniques, relaxation techniques, perhaps, and exercise. So that's a pretty sort of, that would be a whole health system. That would be a multimodal interventions that would incorporate different elements that would address various components of a person. Now, we could also think about ways that would be a little bit more complementary. For example, instead of traditional exercise, one might put Tai Chi, right? And there are certainly some cardiac rehabilitation programs that do successfully incorporate Tai Chi. And that would be just another example of a whole health system that would really be very integrative. But let's look at, for example, some other types. Another example of this might be traditional Chinese medicine, where you might have some components of dietary components, food, herbal formulas. You may have some more sort of psychological / physical kind of component, Tai Chi and acupuncture, and then you might have some sort of more physical, more purely physical interventions like soft tissue manipulation, like Tui-Na, for example, or applications of heat. So these are examples of whole health systems that have not been very much studied as whole health systems, partly because it's not easy to do that. It's a lot easier to study these interventions in isolation, like acupuncture by itself, as opposed to acupuncture as part of a whole health system. There are reasons, though, to look at these whole health systems. And what we think is that integrative health is situated in a very privileged position at the edge, at the boundary, right, of conventional medicine and complementary therapies. It's an opportunity to shed some light into areas in conventional medicine that we may not know or understand, but we could understand better. An example of this, there are blind spots within medicine. Clearly, there are areas in medicine that we just won't see. And a great example of that is someone that's very dear to my heart, and that's connective tissue and fascia. I mean, if you look at a textbook of orthopedics or rheumatology, you're lucky if you find a paragraph on connective tissue or fascia. However, there's a lot of complementary therapies like massage and rolfing that really, they're very interested in this. I mean, that's one of what they work on, right? Is the connective tissue and fascia. And so by understanding the point of view of a complementary therapy like manual therapies, that can really help us ask good research questions. And this is one of the things at NCCIH, we are actually just having a workshop on myofascial pain that's in the fall, that is going to be really looking at developing better imaging methods to look at myofascial pain from the point of view of these different tissues. And so this is directly inspired by complementary therapies. Another thing that we've talked about earlier about connections between systems that we don't really study. My favorite example of this is of a connection between the respiratory and digestive systems, which we have absolutely no knowledge of in conventional medicine, but therapies like yoga or meditation could very well illuminate. And so how do you breathe? Could that influence your stomach, your intestinal function? I mean, we know very, very little about that. But whole health systems specifically, I think, also has the potential to illuminate another kind of what I would call a blind spot. If you look at, for example, the way a diagnosis is made in conventional medicine, and you represented all the signs and symptoms with these sort of little symbols here that I've written, that I've illustrated. If you look at this patient, for example, if this is a patient, you see a lot of red here and a little bit of blue and maybe a couple of yellows. And if all of these are signs and symptoms, and you could say, well, this patient looks like it's got a red disease, right? But then if you turn off the colors and you look at the shapes, and all of a sudden you start seeing, there's a lot more squares than circles. And perhaps if you used a different diagnostic filter, you might say, this person really has a square disease. And it's a little bit even easier if you illustrate it this way. So, it might be that by using different diagnostic systems that are outside of conventional medicine, this could illustrate aspects of physiology that we know very little about. Where this becomes important in research is that if one does research, say, on acupuncture, using a diagnostic filter that is different from that of traditional Chinese medicine, that may actually not yield the best results. We don't know, how much better it would be if we used the traditional Chinese medicine diagnostic filter, because there hasn't been a whole lot of research on that. So these are areas where we feel that there are areas in need of development that would be relevant to whole health systems before one might be able to embark on, say, large-scale clinical trials of these whole health systems, which is challenging. But we think that if we were to develop these areas carefully, that we might be able to really sort of advance the field in a way that's rational and constructive. For example, testing the reliability and validity of complementary diagnostic systems. We feel that this is an area that really should be looked at. Developing and improving phenotypic measurements. That's kind of what I was referring to about the myofascial pain. If all we can do for myofascial pain is palpate a lesion, but we don't have a way to measure it, it's very difficult to know whether a type of treatment, for example, manual therapy, is actually beneficial. We don't have any objective measures of it. Another area is defining treatment protocols for complementary interventions and systems, and establish their fidelity and reproducibility. Doing research on a multimodal intervention is a lot more complicated than doing research on a single defined intervention. So again, that, for example, doing research on traditional Chinese medicine would be a lot more complicated than doing research on acupuncture. So developing protocols that can be reproduced from one institution to another, one research group to another, so that other people can replicate results, or for doing multi-center trials so that a specific intervention can be reproduced with fidelity. Very, very important. And finally, develop, refine, and test clinical research models for multimodal interventions. We've already done a lot of progress in this area at the Healthcare Systems Research Collaboratory that NCCIH is leading with the National Institute on Aging. And there's been a lot of knowledge now that has been derived from learning how to do pragmatic trials in healthcare, embedded in healthcare systems that really sort of preserve the ecological validity, right, of the treatment, but yet also preserve rigorous treatment, research designs. And so we can benefit from all of this expertise that has been developed and to apply this to complementary and integrative whole health systems. Now we have a lot of funding opportunities and mechanisms that we can apply to this, and so there's this whole range of funding possibilities, ranging from all the way from basic and mechanistic to translational to efficacy and pragmatic trial studies that can, as appropriate, be utilized to develop a kind of a pipeline of research that can, approach a field like this. So over the course of the coming year, we're going to be thinking very hard about which type of these sort of research opportunities is most appropriate for looking at these various questions. So as this strategic planning, and as I said, is kind of well underway. We started with a request for information that's just this month, and we certainly hope that as many of you as possible will be able to give your input. You can certainly give your input. I mean, this town hall today is a great also way to give your input. And I know a lot of you have submitted questions. We'll try to answer and address as many of them as we can. We're also going to be planning on holding another online town hall in June that will be open to all. We will be posting a draft of our strategic plan. The plan for this is to do this in the fall. With public comment period, and finally a final plan in early 2021. We're also going to be having ongoing discussions with our advisory council, and we're we feel very fortunate that we've been able to carry on our timeline so far, despite the COVID-19 situation. We'll see how it goes over the next couple of months, but we're very, very grateful, especially for this opportunity that ICIMH has given us to do this town hall, this presentation in town hall today. Instead of, it would have been great to see you in Cleveland, but this is the next best thing. So thank you very much again, and we really look forward to your questions.
Dale, we can't hear you.
I think, Jennifer, it says your bandwidth is low. No.
How about now? Can you hear me now?
Yeah.
Got it. Thank you. So thank you, Dr. Langevin, for that incredible presentation. We have a number of questions already, and if anyone else has a question, please type it into the Q&A section. We will get through as many as we can before we start the town hall. The first question we have is, where does the practice of homeopathy fall within the map of complementary and complementary services fall?
That's a question for me, I imagine. Where does homeopathy fall? Now, homeopathy, it certainly falls within the whole health systems kind of general category, I would imagine. I mean, it meets that definition, right? It's sort of a tricky one because it's not an area where there has been a lot of research. It's sort of, I think that because there's some concerns about the fact that, homeopathy, that the underlying sort of mechanistic of foundation for homeopathy is difficult to even imagine. Not to say, though, that a well-designed research project is impossible. The important thing here that is the most important consideration in all of research is the research rigor, the design of the study, how a study is and there's no subject that cannot be studied, as long as the research question is clear, the hypothesis is well designed, the controls are appropriate. So, it's definitely part of it. I mean, if a good study on homeopathy came through and passed peer review and had a good score, I mean, we certainly would look at it.
Thank you. The next question comes from Janet Kahn. Janet asks, manual therapies are offered physically, but their effects on psychosocial emotional states as well as physical conditions are also documented. When your team is categorizing, are you looking at mode of delivery, only at effect, or both?
So that diagram that I presented about the dietary, psychological, and physical, it was based on the primary therapeutic input, right? That's how it's categorized. Clearly, some different types of treatments, like for example, manual therapy, it's not exclusively physical, even though it's in the physical area. There's certainly a psychological component to massage, as we know, the interaction between the practitioner and the patient. So it's sort of the therapeutic effect is something different. Right? I mean, clearly massage can have effects that are both physical and psychological. But the way that it's presented here, and it's based on a therapeutic input. Mm-hmm.
Thank you. The next question comes from Nikki Monk. Nikki asks, with integration, is there any conversation around what integration means in relation to how it is delivered and by whom? And perhaps how the delivery is integrated into the overall healthcare and or as part of the health system delivery team?
Yes, I mean, this whole thing about the multimodal approach, right? Very often they will involve a team, right? That a multimodal intervention can be delivered by one person or by a team, and that's what a lot of what integrative medicine, for example, groups and clinics, that's what they do. They really integrate various different types of practitioners into one kind of team. So yeah, absolutely. That's an important part of integration. Mm-hmm.
The next question comes from Cecilia Plaza. Cecilia asks, are you planning to incorporate professional competencies for integrative medicine teaching within the strategic plan?
Competencies for teaching. I don't believe that this is in NCCIH's domain. Mary Beth, do you want to answer that?
Sure, that is not part of NCCIH's or NIH's domain, so we would not incorporate that into our plan, as Dr. Langevin said.
Thank you. The next question comes from Anna Panova. Anna asks, when do you think pharmaceutical clinical trials will be run incorporating complementary approaches, say a drug plus yoga or meditation or acupuncture?
Well, we're already doing that. I mean, an important component of the HEAL initiative, for example, right, was to do research on using, for example, complementary approaches like mindfulness, for example, to assist in the medication-assisted treatment, right, for opioid withdrawal, and so these are all areas that we think that it's very, very important that complementary treatments. We look at combining them with medication, and that's a very important thing. We don't, complementary treatments are not meant to be separate, right, from conventional care. And if there's a good combination that sort of maximizes the benefits of both, and absolutely, it's very important to study that. Mm-hmm.
The next question comes from David Fogel. David asks, how do you see the whole health system direction applying and being relevant to the COVID-19 pandemic?
Well, one of the areas that we have already looked at, we've actually issued a notice of special interest, is looking at, for example, the effects of the pandemic on stress. I mean, it's a very, very stressful situation for a lot of people who are experiencing stress, not, from, the social isolation part, of being afraid about, various things, losing their employment, so how does that actually impact the outcomes of an infection? Does, we know that stress is chronic stress is associated with an inflammatory state. And we know that chronic conditions, for example, like diabetes, like obesity, like hypertension, these are the people who have those conditions, like I was listing on that, the chronic diseases. Those are the people who are getting the sickest with this disease. What is the role of stress in there? We don't know. And so we have issued some funding opportunities to look at that in existing studies. These are supplements to studies that are already following cohorts of patients who are undergoing some sort of like mind and body interventions. So this will be very important to think about that in a whole person kind of way.
The next question comes from Daniel Lappin. Daniel asks, what initiatives are underway addressing the whole system multimodal approach to immune and infectious diseases?
Well, like, an example might be, the COVID epidemic. Immune is a different, I think that there are a lot of chronic immune conditions. For example, the sort of rheumatological conditions, even, inflammatory bowel diseases. A lot of these conditions are very much have a, it's interesting to understand better the impact on stress, on sleep. For example, a lot of these conditions are characterized by exacerbations and remissions. Inflammatory bowel disease is a very good example of that. When a patient undergoes an exacerbation, typically they're treated very aggressively with drugs. And then there's a period of remission during the time when there's consideration for de-escalation of the drug therapy. Well, this is a really good opportunity to look at the non-pharmacological approaches to improve general health and overall health, dietary, psychological, physical, and to try to help the patient while they're under remission to prevent another exacerbation from taking place. So paying attention to all of these different factors, I think there's a real need, to help patients who have these chronic type of inflammatory conditions. Very important.
The next question comes from Salvatore D'Angio. The question is, a number of complementary modalities, Chinese medicine in particular, are based on individualizing interventions. Is there a so-called black box model that can incorporate an inclusive whole system approach to diagnosis or therapy and response that could be valid?
Yeah, this is a very important question. And the answer to that is it will take a lot of time and effort to develop the right research models and methods to do those types of studies well. This is, individualized treatments can be sort of researched, but very carefully. Importantly, you can devise these sort of treatment, what we call manualized treatment protocols, so that, a practitioner may have some latitude in deciding which treatment to give to an individual patient, but within a certain sort of envelope, within a certain boundary. And so that even though the treatments are individualized, the intervention itself might be reproducible by, so this is the important thing, is that, treatments can be individualized to a certain extent, but you have to be able to describe what the intervention was.
The next question comes from Michelle Kramer. Michelle asks, where does the study of the biofield come into this plan?
The vital field. I think this refers to kind of like a energetic type of treatment, I imagine. So this is an area, again, like homeopathy, controversial, that, NCCIH has not really funded very much of these studies. I think that, the important thing here is that there has to be research questions that are addressable using the methods that we currently have at our disposal, right? So measuring biofields is technically very tricky. You know, it demands a lot of attention to controls. It's not, you know, impossible, but it's the kind of research that needs to be done in a way that's extremely rigorous. And so, you know, there have been some studies of biofields, for example, in plants and in cell culture, you know, that have been well controlled. And I think that, you know, there's room to grow on that. But it has to be done in a way that emphasizes basic mechanisms and really understanding that first.
I think we have time for one more question before we move into the next portion, the town hall. The question comes from Lisa Taylor Swanson. Lisa asks, well, first of all, she thanks you for your presentation, as many have already done. But she asks, after the new strategic plan is completed, how soon might we anticipate new RFIs reflecting the vision?
Well, that is, you know, we have to first get the strategic plan. You know, like I said, the whole process is going to take about a year. And then, you know, we develop RFIs all the time, and some of the thinking for the strategic plan is already being incorporated. And I've already talked about some initiatives that we're developing around myofascial pain, around interoception, around stress, and so some of these things are already sort of being in the pipeline. You know, it's hard to say. I can't say exactly a date. But you know, these RFIs are being developed all the time. This, by the way, I should say the strategic plan is not radically different from what we were doing before. You know, it's an evolution, and you know, we're still going to be doing a lot of the similar, you know, our research that we've done, that we funded previously on pain and mind and body therapies, natural products is going to continue.
Well, thank you again,